So I'm going to give two presentations on stroke and cerebrovascular disease. It's probably not enough because it's an extremely important topic. And the first talk will really be on stroke caused by cerebral hemorrhage. We generally think of stroke as being caused by either cerebral or intracranial hemorrhage or ischemic change. And then related to ischemic change is the whole issue of anoxic ischemic encephalopathy, which I'll touch on as well. Many people have different definitions of stroke. In fact, I'm on a panel of the American Heart Association that is trying to redefine the clinical and pathologic features of stroke. So it's a work in evolution. But actually, this is a definition I quite like and that I always give to the medical students. It's from an old edition of Victor and Adams, which was one of the standard neurology textbooks, an edition several years ago. But basically, they defined stroke in clinical terms rather than in neuroimaging or pathologic terms. Obviously, with new advances in imaging, the definition of stroke is evolving with the ability to image strokes very effectively. But they defined it at the time, and this book was really written at the time when CT scanning was coming into use, which wasn't the greatest thing for identifying strokes. But the definition was really of a rapidly progressive, irreversible, non-convulsive neurologic deficit. And the reason they gave this definition was that, as you all know, stroke syndromes are not necessarily caused by cerebrovascular disease. I'm sure you've all seen very rapidly evolving tumors, hemorrhage into tumors, very rapidly evolving infections that can really mimic cerebrovascular disease. So it was really a clinical definition that when stroke is caused by cerebrovascular disease, in other words, when this rapidly progressive, irreversible, non-convulsive neurologic deficit is caused by cerebrovascular disease, it usually results from an infarct, most commonly, at least in Western populations, or an intracranial hemorrhage, accepting the fact that, of course, a very hemorrhagic infarct can turn into an intraparenchymal hemorrhage, so the distinction is somewhat artificial. How do I advance?
Using this?
Yeah.
Yeah, it's arrows, one or the other.
Oh, I tried that. And if I could get rid of the icons on the side and on the bottom. Can't get rid of those. Okay, all right. Okay. That's not my talk.
Okay. So this is working out in the top of the pointer.
All right. Okay. So just a recapitulation of the stats on stroke. Even though stroke is really a clinical term, we still use it to describe some pathologic terms. Although we realize that stroke itself has no specific neuropathologic correlate, it's really got a spectrum of abnormalities that describe it. So actually, the incidence of hemorrhagic versus ischemic stroke, as you all know, varies among populations. In so-called Western populations in North America and Europe, infarct compared to intracerebral or subarachnoid hemorrhage is much more common. So in Western populations, ischemic infarcts are about 80 to 85% of strokes versus about 6 to 12% for intracerebral hemorrhage and about 4 to 7% for subarachnoid hemorrage. The unfortunate thing, as you know, is that subarachnoid hemorrhages very often occur in much younger individuals than infarcts, whereas infarcts are almost an inevitable consequence of aging. So as we're seeing patients in their 80s and 90s, ischemic infarcts are much more common. When you go to Japan, the comparable ratios are much different, so that just over half of their strokes are ischemic infarcts, about 30% are said to be intracerebral hemorrhages, and about 14% are said to be subarachnoid hemorrhages. So when you read the very large clinical series of subarachnoid hemorrhage and intracerebral hemorrhage, very often they come from Japan. And Australia has figures that are somewhat in between Japanese figures and figures for the Western population. This is an example of an ischemic infarct, although I'm going to spend most of my time talking about cerebral hemorrhage. This is an example of an ischemic infarct in the left putamen. And again, in my pictures, left is on the left and right is on the right. So you can see that there is a cystic cavity in the putamen, and there's enlargement of the left lateral ventricle. So this is really kind of enlargement of the ventricle because of collapse of the tissue, because of this cystic cavity in the putamen. So I'm calling it an ischemic infarct. It might be more accurate to call it an area of cystic encephalomalacia, because as you know, hypertensive bleeds can occur in the putamen, And in fact, this may very well have been a hypertensive bleed that has resorbed, leaving the cystic cavity. So it might not be an ischemic infarct at all, so much as a resorbed cerebral hemorrhage. And when we see a specimen like this at autopsy, it sometimes can be difficult to discern whether it actually was an ischemic infarct or whether it was a cerebral hemorrhage that has been resorbed. And usually we go by the clinical history. Imaging, obviously, somebody who had a lesion like this would have been neurologically symptomatic, definitely, and was probably imaged, so we would know whether, in fact, there was a putaminal hemorrhage that is now resorbed, leading to this enlargement of the left lateral ventricle. And the right basal ganglia here look entirely normal. The right lateral ventricle looks entirely normal. So the point is that actually many, many years after ischemic lesion or a hemorrhage has occurred in the brain, they kind of converge in their appearance. They can look really quite similar. How would we sort out the etiology of this? Obviously, we would look at the evidence for microvascular disease in the brain or evidence of risk factors for ischemic stroke, such as atherosclerosis of the cervical arteries or the intraparenchymal arteries, arteries at the base of the brain. This, by contrast, is an intraparenchymal hemorrhage in the right superior frontal lobe. If you didn't know the age and the clinical circumstances of this patient, the etiology of this would be difficult to discern. If I told you this was a 90-year-old individual who developed a sudden intraparenchymal hematoma like this, your number one etiology would probably be amyloid angiopathy. If I told you this was a 45-year-old who had a liver transplant, was in liver failure, awaiting a liver transplant, you would think that this hematoma might be on the basis of platelet abnormalities with or without a coagulopathy. What's interesting is that actually this hematoma, massive though it is, has really not caused a huge amount of mass effect here. So I think this patient actually survived the acute hematoma by a few days, and she was actually a young person who had a lot of coagulation abnormalities, coagulopathy, liver problems, and so on. There was no attempt, therefore, made to evacuate this hematoma. As many peripheral hematomas do, this one communicated directly with the subarachnoid space. And as you know, that's extremely unusual for hypertensive bleeds to do. Hypertensive bleeds can actually extend into the subarachnoid space, but it's usually through the ventricular system. They extend into the ventricular cavity because they're usually centrancephalic hemorrhages. And then through the ventricular cavity, the blood percolates through into the subarachnoid space. But direct extension of a hypertensive bleed from the brain parenchyma into the subarachnoid space is extraordinarily unusual. This is from a nice review of intracerebral hemorrhage, primary intraparenchymal hemorrhage, just showing something that you all know, which is that hematomas can evolve over hours or days. They can start out as fairly small hematomas, as in the right thalamus basal ganglion here, and expand and get very, very large over time. And that's true of amyloid angiopathy-related bleeds as well. So once they start bleeding, they can actually increase in size quite rapidly. And these days, you're much more on the cutting edge of the treatment of intracerebral hemorrhage using surgical and endovascular or endoscopic techniques. Many of these hematomas are now, my understanding, are actually evacuated at the bedside, and many of them are evacuated intraoperatively. And it's very, very important when that happens to evaluate the removed blood clot together with the brain fragments. And I'll show you an example of that. And actually, Justin Dye has been working on a ongoing project that we have looking at the neuropathology of the brain parenchymal fragments that are removed together with the blood clot, because they can be extremely informative and can tell us the etiology of the hematoma very, very, very frequently. Some causes of intracranial hemorrhage, speaking now but globally about intracranial hemorrhage, not intraparenchymal hemorrhage. So obviously craniocerebral trauma, cerebral contusions can become very large, can turn into hematomas. Deep hemorrhages within the brain are rather unusual as a sequela of traumatic brain injury. In other words, it's unusual to get a large ganglionic or white matter hemorrhage that is secondary to trauma. They're usually superficial with an excess of blood in a fairly superficial lesion. Berry aneurysms of course, are a common cause of intracranial, usually subarachnoid hemorrhage. But remember that a berry aneurysm, and I'm sure you've all seen examples of this, a berry aneurysm that points directly into the brain parenchyma can present almost exclusively with an intraparenchymal hemorrhage with a very minimal subarachnoid component. Just depends on where the dome of the aneurysm is situated. Various types of vascular malformation, the two most common that we see, I'll show you pictures of these, are arteriovenous malformations. by far the most common lesion that we see that causes intraparenchymal hemorrhage, at least the most common lesion we see in surgical pathology, and then cavernous hemangiomas or cavernous malformations. Venous angiomas and telangiectasies are usually an incidental finding at autopsy and generally are not symptomatic. Venous thrombosis, I'll show you an example of how venous thrombosis can look like an intraparenchymal hemorrhage. There are a number of drugs that can lead to intraparenchymal hemorrhage, both recreational drugs and medicinal drugs. And hypertensive hemorrhage we still see less frequently than we used to because hypertension is so effectively controlled. Probably the most common microangiopathy that we see as a cause of intraparenchymal hemorrhage is amyloid angiopathy. I'll say moya disease is on this list, but I've never seen a parenchymal hemorrhage related to that. We do rarely see vasculitides that can lead to parenchymal hemorrhage. And then coagulopathies or platelet disorders. In a hospital like this where you have a lot of leukemics, a lot of patients undergoing chemotherapy and so on, that's a very, very common cause of intraparenchymal hemorrhage. I would say when the neurology residents are called to see somebody with an intracerebral hemorrhage, probably the most common cause is one of these abnormalities rather than a hypertensive bleed or an amyloid angiopathy-related bleed. And intracranial hemorrhage is subdivided into epidural, subdural, subarachnoid, and intraparenchymal hemorrhages. I'm not going to go over that. A couple of words about subarachnoid hemorrhage. Subarachnoid hemorrhages, you know the statistics on them, that they very often are fatal in the field. Somebody, as soon as they have their subarachnoid hemorrhage, dies within a few minutes. Although we're always asked in cases where somebody dies, like on the wards instantaneously, we're asked to evaluate them for subarachnoid hemorrhage. In fact, as a cause of sudden unexpected death, or SUD, that is instantaneous within seconds, subarachnoid hemorrhages are usually not a major cause. Usually a subarachnoid hemorrhage will take at least a few minutes to evolve. The patient will complain of dizziness or headache or some other neurologic abnormality for a few seconds or a few minutes. It's not like a cardiac arrest which leads to instant death. The one exception to that is probably a baryaneurysm that is in the vertebrobasilar system, which can lead to very massive compression of the brainstem within a few seconds, and that can produce almost instantaneous death. There are other things in the nervous system that can actually produce sudden unexpected death, but subarachnoid hemorrhage is a little bit lower down on the list. This is an example of a very large subarachnoid hemorrhage from a baryaneurysm. And you can see that blood fills the basal cisterns, and there's quite a bit of subarachnoid blood over the base of the brain, and there was over the convexities as well. When we encounter a patient like this at autopsy, we generally try to find the baryaneurysm right at the time of the autopsy. In other words, we don't just fix the brain. The temptation is to look at this huge collection of blood in the basal cisterns and say, just fix the brain. We'll look for the baryaneurysm after the brain is fixed. That's the wrong decision to make because the blood is much easier to dissect away in the fresh state. And people worry that they're going to destroy the baryaneurysm that caused the hemorrhage, but that almost never happens. You can isolate the aneurysm, find the aneurysm, and isolate the cause of the subarachnoid hemorrhage quite easily at the time of autopsy. When this was done in this particular case, the prosector was rewarded with, I guess that would be me, the prosector was rewarded by finding this anterior cerebral, anterior communicating artery aneurysm indicated by the swivel stick. The chairman of the department where I trained was a big-time drinker, so he liked having swivel sticks around the morgue. And so you can see that there is not only an aneurysm at the anterior cerebral, this is the A1 segment of the anterior cerebral, the anterior communicating artery here, one of the common locations for baryaneurysms, but you can even see this little tear in the aneurysm, which is actually the bleeding site. The important thing is to remove the blood from the basal cisterns at the time of the autopsy. The second thing to do is to, just because you've found one aneurysm, you don't stop your search, because some patients, as you know, have multiple baryaneurysms, so you look for other aneurysms. But in this case, this was the only baryaneurysm that was found. As I mentioned to you, the blood can fill the basal cisterns, but can also track over the subarachnoid space. So this is an example of somebody who's got very widespread subarachnoid hemorrhage, particularly over the left cerebral hemisphere, but also over the right cerebral hemisphere, filling the sylvian fissure. And so there's a huge amount of blood overlying the brain parenchyma, and you're aware of all the complications of subarachnoid hemorrhage, vasospasm, and then later on hydrocephalus that can require shunting. We don't always see this amount of blood over the convexities, but in this case there was a large amount of blood, and I can't remember where the berry aneurysm was in that case. You know that the common locations for berry aneurysms depend very much on where you trained. Since I trained in London, Ontario, which was a big center for the treatment of vertebrobasilar aneurysms because of people like Charles Drake and Skip Peerless, we saw a disproportionate number of posterior fossa aneurysms. It would be not uncommon in an average week to do 2 or 3 basilar tip aneurysms at autopsy. And Dr. Drake was fantastic. He used to come down and help us dissect the circle of Willis to visualize the single aneurysm or the multiple aneurysms. But the general teaching is that if you draw a line through the posterior communicating artery, about 70 to 80% of berry aneurysms will be on the anterior circulation in these areas that are well known to you, the loci that are very well known to you, and about 10 to 20 to 30% will be posterior fossa aneurysms, the most common location being the basilar tip, but you can get a berry aneurysm anywhere on any vessel coming from the basilar artery, and they almost always occur at branch points. As you know, they're very rarely peripheral. If you have a peripheral aneurysm, an aneurysm over the convexities, you always worry about a mycotic or an infective aneurysm, and they're usually multiple, and they're usually not treated by clipping. They're treated by treating the underlying cause of the mycotic or infective aneurysms. Histologically, this is the defining feature of a berry aneurysm. This is actually a normal artery stained with elastica van Giesen. So you see the media, very dense with smooth muscle cells, nicely demonstrable using a smooth muscle actin immunohistochemistry. And this fine line, or this very dense line, is actually the internal elastic lamina, which is somewhat corrugated, looks corrugated because it tends to collapse a little bit when the artery is fixed. But this is a normal internal elastic lamina, and there's no evidence of intimal hyperplasia here. By contrast, a berry aneurysm is characterized by weakening of the vessel, and if you do an elastica van Giesen stain in the wall of the berry aneurysm, you will see no elastica, which is presumably why the vessel wall becomes weak and prone to rupture. Another interesting phenomenon here that we occasionally see at autopsy in incidental berry aneurysms, that is that there is quite a bit of atherosclerotic change superficial to the wall or the dome of the aneurysm, and that occurs not infrequently, especially in aneurysms that have never ruptured. How often do we see berry aneurysms at autopsy as an incidental finding? Infrequently. The figures that are given are that you can find a berry aneurysm in about 1 out of 100 or 1 out of 200 general autopsies in which they've been totally asymptomatic. I think that figure is a little bit high, but it depends on how carefully you look. If you looked at every branch point of the circle of Willis using histologic sections, you might see some nascent berry aneurysms, but in fact, as a well-defined berry aneurysm, we see them quite infrequently. We can also see the way that the aneurysm was treated. This is one of Dr. Drake's patients in which the aneurysm has actually been clipped. There was a very large posterior P1 segment posterior cerebral aneurysm here. The aneurysm itself is somewhat collapsed, but you can see the clip on the aneurysm. And you can identify all of these clips if necessary for in a forensic case or whatever by going. There are nice papers published summarizing the appearance of all the different clips that you use in clipping a berry aneurysm routinely. Of course, these days we don't necessarily clip berry aneurysms. You usually treat them using endovascular techniques, and that leads to its own set of complications and interesting abnormalities at autopsy. But I would say we probably see less clipping of berry aneurysms now than we do endovascular treatment, although some are still clipped. We looked very carefully here for another berry aneurysm on the circle of Willis and found only this one. Occasionally there are an incidental finding at autopsy. This is a small middle cerebral artery bifurcation aneurysm found incidentally at autopsy. So here's the M1 segment of the artery. This is stained with an elastica stain. And you can see this outpouching of the artery, kind of a multi-lobed outpouching of the artery. These are the distal branches, the M2 segments of the middle cerebral artery. And there's a tiny aneurysm here at the end of the middle cerebral, just at the branch point, with the branches of the M1 segment of the middle cerebral artery, in which that classic absence of the elastic was identified. And had this patient lived another 10 or 15 years, he or she might have developed subarachnoid hemorrhage. Just to show you some examples of small intraparenchymal hemorrhages, sometimes not so small, related to medical conditions. You know that there are, because we have a big liver transplant program, bone marrow transplant program, very aggressive treatment of leukemias and lymphomas here. There are a lot of patients on the wards who are profoundly thrombocytopenic, who have coagulopathies, who have leukemia. And so we very commonly see small parenchymal hemorrhages as a complication of these disorders. This was somebody who had DIC, and you can see that there is a fairly large basal ganglia hemorrhage, although it hasn't really had any mass effect here. The ventricles look entirely relatively normal, maybe a little bit of compression of the left lateral ventricle. It's interesting that this hemorrhage is chosen as the locus in which it occurred, an area where hypertensive bleeds are quite common. So this patient might have had a small degree or a slight degree of hypertensive microvascular disease that predisposed them to rupture in this area. Anyway, this was really the only parenchymal hematoma within the brain. This is an example of how a hemorrhagic infarct can really resemble an intraparenchymal hematoma. This was a patient, an elderly patient, I think in his 90s, whose main pathology was really Alzheimer's disease. You can appreciate a little bit of cortical atrophy here with enlargement of the sulci and shrinkage of the gyri. But he also had some cerebrovascular disease, and he actually had this watershed infarct between the anterior cerebral artery and the middle cerebral artery. And in fact, you could almost argue that this is kind of a triple watershed: anterior cerebral, posterior cerebral, middle cerebral. He had a hemorrhagic infarct, so he had an ischemic infarct and then reflow into the infarct. And the reflow was really so massive that it looked like an intraparenchymal hematoma, but in fact, microscopically, it really looked like a hemorrhagic infarct rather than a hematoma. This is another example of a small hemorrhage related to, I think this was an individual with liver failure. Why do I say that? A small oval hemorrhage, but notice that it's surrounded by greenish-yellow material. So there was a moderate degree of edema around this hematoma. And whenever you have edema, presuming it's vasogenic edema or assuming it's vasogenic edema, if the patient is jaundiced, the bilirubin will actually leach into the surrounding brain, and you'll actually have greenish-yellow discoloration, which kind of marks the area of edema around the hematoma. An example of sinus venous thrombosis and how it can resemble intracerebral hemorrhage. Usually sinus thrombosis leads to large areas of hemorrhagic necrosis in the brain that really look very much like embolic infarcts. When you look at them, but they can look like solid hematomas. And when you examine them at autopsy, they can really look like very peripheral hematomas involving the cortex and the subcortical white matter. But in fact, this was actually an example, a very unfortunate young woman who probably had extensive sinus thrombosis on the basis of contraceptive intake. She had no other risk factors as far as we could tell. Causes of acute hypertensive reactions that can be complicated by intracranial hemorrhage. Pheochromocytomas can do that, acute glomerulonephritis, eclampsia. A number of different medications have been implicated, all of which you're familiar with. Medications that are taken as medicinal, taken as therapy, or are taken as recreational drugs, cocaine and amphetamines, so-called speedballs, which can lead to massive intraparenchymal hemorrhages, and you see those probably more commonly than we do, because most of those patients, if the hematoma is not fatal, obviously they're going to be admitted. And do you generally evacuate those clots or just leave them? Okay. Okay. And if it's fatal, then they go to the coroner's office. So a number of other conditions that can lead to hypertensive reactions leading to hemorrhage. Hypertensive hematomas. We shouldn't really see many of these if the primary treatment of hypertension is totally effective, which it's obviously not. Many people don't comply with their medications. Many people don't even see the physician. But hypertensive hemorrhages are usually, as opposed to amyloid angiopathy-related bleeds, are usually centroencephalic. So they're in the deep central gray matter, the common locations being the basal ganglia, thalamus, pons, and cerebellum. And of those, the most treatable, eminently treatable, are usually the cerebellar hematomas, as you know. Lest we think that hypertensive bleeds occur only in elderly individuals. This was actually an autopsy on a 26-year-old who was severely hypertensive with a very strong family history of hypertension, was non-compliant with medications, and developed a massive left basal ganglia hematoma with significant compression of midline structures and left to right shift of the midline structures. This hematoma did what hypertensive bleeds often do. They go into the ventricular system, and then they hit a little bit of subarachnoid blood here from the extension of blood into the ventricular system, but this was fatal within a few hours of having occurred because of herniations, fatal herniations. This is a hematoma that had a little more time to develop, or at least to produce symptoms. So this looks like it's in the early stages of organization. It's still a basal ganglia hematoma, somewhat triangular shaped. And what's interesting is that it looks like there is actually some ischemic necrosis in the middle cerebral artery territory. And one of the things we thought might have happened in this individual was that the hematoma actually extended, it compressed the middle cerebral artery, or branch of the middle cerebral artery, and then there was secondary ischemic necrosis in the middle cerebral artery territory. And there is a significant amount of compression of midline structures here from right to left, and the hematoma seems to be extending into the ventricular system, though it's not as prominent as in the hypertensive hematoma that I just showed you. This is obviously not a survivable hematoma. This is a pontine hematoma. Although this patient actually survived by several weeks. He was maintained on life support for several weeks, but a very large hypertensive bleed sitting in the, basically obliterating the pons, I guess is the only way to say it. Probably began in the basis pontis, but really is extended into the pontine tegmentum and extended into the fourth ventricle as well. So the pons is a not uncommon location for hypertensive bleeds. What's the microvascular substrate for these bleeds? Hypertensive microvascular disease, which can usually look like onion skin type thickening, smooth muscle cell hyperplasia in the vessel wall. And there may or may not be Charcot-Bouchard microaneurysms, examples of which I'll show you. And sometimes this entity is referred to as lipohyonosis. This was a name that was given to hypertensive microvascular disease by Miller Fisher in the 1960s. And lipohyonosis is actually not a bad term, because what happens in classic examples of this vasculopathy is that there is hyalinization of the vessel wall, and then there are significant numbers of macrophages that are in the vessel wall. So there are lipidized macrophages and hyalinization. This is a pretty classic example of lipohyonosis, but it's not always this clear-cut or this dramatic. And unfortunately, there are a certain numbers of individuals who have pretty classic hypertensive bleeds in which we see relatively little evidence of hypertensive microvascular disease. So there might be factors other than simple hypertensive microvascular disease that are causal here. One of my favorite topics, amyloid angiopathy-related bleeds, which I think, whereas hypertensive bleeds should really be on the decline, given that hypertension is being treated very aggressively and quite effectively, although not in everybody for the reasons we discussed. By contrast, amyloid angiopathy is likely to become a more and more common cause of intraparenchymal hemorrhage. Why? Because amyloid angiopathy is strongly associated with brain aging and Alzheimer's disease, and we all know the patient population is aging. The numbers of individuals who are living to their 80s and 90s, even centenarians, is getting larger and larger. And the major association between amyloid angiopathy, or the major association of amyloid angiopathy, is with brain aging and Alzheimer's disease, and I'll show you the biochemical links to them in a minute. These hemorrhages are different than hypertensive bleeds because they're usually peripheral or lobar hemorrhages. You almost never see amyloid angiopathy causing a brainstem or a ganglionic hemorrhage, but there have been rare examples of severe amyloid angiopathy in the cerebellum that produced an intraparenchymal hemorrhage, but that's extremely unusual. It's almost reportable. Whereas amyloid angiopathy-related cerebral hemorrhages are usually lobar and very superficial and will dissect directly into the subarachnoid space. This is usually the patients survive an individual bleed, but once they have one amyloid angiopathy-related bleed, they are at major risk for developing another one, because the microvasculopathy is usually very widespread throughout the cortex. And remember that amyloid angiopathy involves primarily, almost exclusively, cortical and meningeal arteries. It does not involve white matter or deep central gray matter arteries. This is a massive, fatal amyloid angiopathy-related bleed that's basically obliterated the left parietal lobe and really has very extensively gone into the subarachnoid space. These are from the same brain. This is just a slightly more anterior slice. Again, a very large lobar hemorrhage that almost seems to have accomplished the unthinkable task of extending into the ventricle and into the subarachnoid space at the same time. This patient died from this hematoma, as did this individual. Now, you might say, if the microangiopathy is cortical, why are the hemorrhages so often in the subcortical white matter? And I don't really have a good answer for that. I've always thought of the white matter as being the path of least resistance for a hematoma when it occurs, but I don't have really good evidence for that. But it is very common to see an amyloid angiopathy-related bleed related to microvasculopathy in the cortex, extending into the subcortical white matter, and obviously with a massive mass effect, or tremendous mass effect here, compression of midline structures from the right to the left side, and again, focally direct extension of that blood into the subarachnoid space. You might ask, if amyloid angiopathy is meningocortical, do you ever get pure subarachnoid hemorrhage from severe meningeal amyloid angiopathy? And the answer to that is a qualified yes. Yes, you do, but it's extremely rare compared to the more common causes of subarachnoid hemorrhage. And I think the few papers I've seen documenting this very well came from Japanese centers. Another amyloid angiopathy-related bleed with a moderate degree of shift of midline structures and sitting in the right frontal lobe, really compressing the Sylvian fissure here. But a nice, well-circumscribed hematoma. This patient also had some liver abnormalities. That's why the surrounding brain parenchyma shows this greenish-yellow discoloration. And a slightly higher power view of that hematoma. This, again, an amyloid angiopathy-related bleed, lobar, again, extending into the subcortical white matter, but presumably originated from amyloid angiopathy in the cortex. Very minimal mass effect here. I'm not sure what the philosophy is of treating these surgically, because if you leave them alone, they generally will resorb and leave a cystic cavity in the brain. That might take weeks or months. But some people are aggressive in removing them. There was a belief in the 1970s and 80s that because the amyloid angiopathy leads to a very marked fragility of the vessels in the cortex and the meninges, that in fact you did more harm than good by trying to evacuate the hematoma, but that belief is no longer held, and so I think it's an entirely reasonable approach to try to evacuate these hematomas using either endoscopic techniques, which I know some of the surgeons here use, or an open craniotomy. What does amyloid angiopathy look like microscopically? This is an appearance well known to Justin. I think he gave a talk on this at an amyloid angiopathy meeting we had here a few months ago. What happens is an amyloid angiopathy, a very interesting phenomenon, and that is that the smooth muscle cell layer of the arterioles is obliterated. The smooth muscle cells disappear and are replaced by a fibrillar eosinophilic material by light microscopy. And if you do electron microscopy on the amyloid-laden vessels, you see amyloid fibrils in the media. And that happens, this is obviously a section of the cortex because you can see neurons. It's really happened to all of the arterioles in this particular section of the cortex. So obviously, if you lose the cells that are the kind of mediators of autoregulation in the peripheral circulation in the arterioles, if you have any change in pressure or anything that predisposes to hemorrhage, if you have, say, a spike in blood pressure, it's very likely that these vessels are going to rupture and lead to intraparenchymal hemorrhage. Although when we look at the hematomas, it's quite unusual for us to actually see the rupture point of the arteriole that led to the hematoma, although once in a while we can fortuitously see this. And if you want to demonstrate these by immunohistochemistry, so light microscopy is quite adequate to make the diagnosis. We can do immunohistochemistry using antibodies to A-beta protein, and it will spectacularly decorate these vessels. And that probably explains the biochemical link between this microvasculopathy and Alzheimer's disease. In fact, it turns out that the A-beta protein, or the A4 protein that we now know as A-beta protein, which was discovered in 1984, was actually isolated not from parenchymal amyloid, but from microvascular amyloid. And so a biochemist isolated these vessels from somebody with severe amyloid angiopathy, studied them biochemically, and developed antibodies to them. And those antibodies actually label the amyloid in the vessel wall. So very, very tightly linked to Alzheimer's disease, but we do see people with amyloid angiopathy who do not have other sequelae of Alzheimer's disease, who are not cognitively impaired, although unfortunately very often after they have a bleed, it will kind of unmask their cognitive impairment, and they don't really recover to baseline and develop other manifestations of Alzheimer's disease. So A-beta is a very good antibody to use to demonstrate the microvasculopathy. Why do they actually bleed? I mean, there's a whole, if you accept the fact that amyloid angiopathy is linked to Alzheimer's disease, there are millions of people walking around with some degree of amyloid angiopathy because about 80 to 90% of people with Alzheimer's disease have microvascular amyloid in their cortex and meninges. The reason they bleed tends to be because of secondary changes that occur in the vessel wall, such as fibrinoid necrosis, as you can see here, and microaneurysm formation. So this is actually a section stained with an antibody to A-beta protein. This is obviously a small meningeal artery from somebody with an overwhelming degree of amyloid angiopathy. And you can see that the A-beta antibody only stains a portion of the vessel wall. The rest of the vessel wall is this flask-like enlargement, and there actually are numerous macrophages in the vessel wall, so that this is actually a Charcot-Bouchard type microaneurysm associated with amyloid angiopathy. In what context was the term Charcot-Bouchard microaneurysm first used? Patrick? I mean, I'm showing you a Charcot-Bouchard aneurysm associated with amyloid angiopathy, but when was the term first used? It was almost equivalent to, the term was used to describe microaneurysms that occur with hypertensive microvascular disease. When people looked very carefully in autopsy studies starting in the 1960s and 70s at the brain parenchyma around a hypertensive bleed, they would very often find these small aneurysms. But I must say now we see Charcot-Bouchard aneurysms much more commonly in the context of amyloid angiopathy and other microangiopathies like CADASIL and so on than we do in hypertensive microvascular disease. So the best Charcot-Bouchard microaneurysms we see are really not associated with hypertensive disease these days, but that's the classical association. But I think the term Charcot-Bouchard microaneurysm should really be used to describe microaneurysms that occur in the context of any type of microvascular disease affecting cerebral arterioles. And this is an example of other features that you can see with amyloid angiopathy. This is an example of somebody who has developed a granulomatous angiitis related to amyloid angiopathy. And in one of the cases that Justin studied, we actually fortuitously, in the blood clot that was removed, we could actually see a small microaneurysm on an amyloid-laden vessel that seemed to be the result of very, very severe inflammation in the vessel wall. So it was like 3 disease processes in one histologic section. That's not, this picture isn't from that case. But very often there can be macrophages in the vessel wall that you can highlight using antibodies to macrophages like CD68 as well. So the amyloid angiopathy seems to set up the vessel wall for a lot of other pathologic changes in the vessel wall, secondary degenerations. And we think that it's those secondary degenerations that really predispose to intraparenchymal hemorrhage. Now, what we don't know are which patients are at risk for developing those secondary degenerations that lead to amyloid angiopathy-related bleeds. And if you look at the brain of somebody with amyloid angiopathy many years after they've had their hemorrhage, this is what the brain looks like. This is actually an individual who had multiple amyloid angiopathy-related bleeds. And you can see there's kind of cystic collapse of the right parietal lobe where the hematoma had occurred, and a little bit of orange-brown discoloration here related to the previous hemorrhage. So this is the take-home message that, again, Justin is acutely aware of this, but I'm sure you all are. It's really important to examine blood clot removed from an intraparenchymal hematoma very carefully, because there will almost always be small fragments of brain parenchyma present, and you can make a diagnosis of a microvasculopathy, primary or secondary tumor, vascular malformation, cavernous hemangioma, arteriovenous malformation, very easily, very often on H&E stained sections. And the microvasculopathy that we see very commonly from these peripheral hemorrhages is amyloid angiopathy. And you can diagnose that by H&E, but you can also confirm it by Congo red stains, or what we prefer to do these days are A-beta immunohistochemistry. Just some other dramatic pictures of what amyloid angiopathy looks like. Congo red is still perfectly fine to make the diagnosis. This is actually from an evacuated blood clot, John Frazee case from several years ago. And you can see this overwhelming thickening of the vessels in the vessel wall. And the sections were stained with Congo red, and it gave this very characteristic reddish-pink appearance to the vessel wall. And when that was polarized, we were able to see this very characteristic yellow-green birefringence in the vessel wall. And this is what amyloid angiopathy looks like on H&E at a higher magnification. This, again, is from a surgical patient. I think it was an 85 or 86-year-old lady where the clot was evacuated, and the very characteristic amyloid angiopathy is very dramatic here and surrounded by a few red blood cells, acute hemorrhage here. Interestingly enough, this lady had other sequelae of Alzheimer's disease, and I think she passed away just a few months later from another amyloid angiopathy-related bleed. But again, if you ever shown on the boards a picture of an arteriole and you're scratching your head wondering where the smooth muscle cells are, they probably want you to make the diagnosis of amyloid angiopathy. And if they're good enough to tell you that it's from the brain of an 85-year-old or 90-year-old individual, that kind of clinches the answer. Another view there. And again, in a surgical specimen stained with antibodies to A-beta, overwhelming deposition of A-beta in the vessel wall. But if you did smooth muscle actin, you would find very little smooth muscle remaining there. I mentioned to you that we always, when we have a case like this and we have enough brain parenchyma, we always look for other features of Alzheimer's disease and very frequently find it. So in this 85-year-old lady, this is actually a section stained with an antibody to tau or phosphorylated tau. And you can see that obviously the amyloid-laden vessels are not labeled, but there are neuropil. There's extensive deposition of phospho-tau in the neuropil, and then there are numerous neurons here that are tau immunoreactive. So she really fulfilled the criteria for very advanced Alzheimer's disease. And we could see tau immunoreactive senile plaques as well in many areas of her cortex. Let me just say a couple of words about, just before finishing, about, so amyloid angiopathy, the most common clinical context is obviously brain aging and Alzheimer's disease. But we actually see it, don't stop me yet, you can turn the lights on. One more slide yet. I'll show this slide. Thanks. It turns out that there are many familial forms of amyloid angiopathy, some of which are A-beta immunoreactive, some of which are not. And they've actually been informative, like many rare genetic diseases, in providing very interesting data about the pathophysiology of amyloid angiopathy. And in fact, one of the most interesting forms of amyloid angiopathy, without other features of Alzheimer's disease, occurs in the Netherlands. It's called hereditary cerebral hemorrhage with amyloidosis of the Dutch type, HCHWA-D. It's a rare disorder, but is a very, very important cause of stroke and cerebral hemorrhage in that population. It's an autosomal dominant disorder related to a mutation in the amyloid precursor protein gene. And so the protein that is deposited in the vessel walls is a beta protein. Actually, the first form of familial amyloid angiopathy that was discovered was in Iceland. You might say, who on earth cares about Iceland? But in the southwest region of Iceland, there is a very, very common form of amyloid angiopathy, autosomal dominant, which is a major cause of death of people in their 30s and 40s. There is a Center for the Study of the Icelandic form of amyloid angiopathy in Reykjavik. So the Icelandic form of amyloid angiopathy is extremely common there, not elsewhere. In fact, it's not seen elsewhere. And it's actually got nothing to do with A-beta protein. It has to do with a protein called cystatin C, which is a protease inhibitor that is deposited in the vessel walls. There is a form of Danish and British amyloid angiopathy, but those are not usually associated with cerebral hemorrhage. However, there is a Dutch form of amyloid angiopathy, which I've already mentioned to you as an extremely common cause of cerebral hemorrhage there, and it is related to mutations in the amyloid precursor protein gene. And there now are familial forms of amyloid angiopathy, a rare form that's been discovered in Iowa, but it's not actually related to stroke. It's related to Alzheimer's disease, a familial form of Alzheimer's disease, and there's not very much known about it yet. But interestingly enough, the familial form of amyloid angiopathy that occurs in Iowa is associated with other features of Alzheimer's disease, and actually is associated with a codon 694 mutation in the amyloid precursor protein gene. So it turns out that there is a little cluster of, or there's a hot spot in the amyloid precursor protein gene where if you have a mutation, a point mutation, the likely phenotype is going to be amyloid angiopathy, with or without